So Dr. Abram gave you an absolutely outstanding overview of epilepsy. And what I will do is actually have one foot in each camp, the pediatric and the adult camp. And really, you can't talk about this condition without talking about it as a spectrum type of problem. And what I'd like to do is actually give you some of the non-discussed issues in epilepsy that we talk about. We always talk about certain aspects of it, but really to give it the blood and soul of the whole thing. So that's what the focus of this talk will be. And with that, the key issues and decisions are what you've just heard, but just to reiterate them, is the key decisions are on the steps to seizure freedom, because that's where it's at. And you want the right diagnosis, the right classification. Dr. Abram really talked very nicely about how that's classified. You want the right treatment plan. He talked about an acute seizure plan. What's the plan for your child? And that deals with education, the rescue that he talked about very correctly, and the right AED. Now, what we'll do is talk a little bit about the areas suggesting it. All the focus is always on the seizures, as it should be, but there are a whole bunch of things we don't think about, and that has to do with medication side effects, and they can be pretty awful. School, big issue. Driving, a huge issue. Work, family, and children, and so and not least of which are parents, siblings, and caretakers. Oftentimes we focus on the parents or the caretakers, but we don't focus on the other children. When you have a child with chronic illness, the other children oftentimes either are neglected just because so much of attention is needed on one, and I can see families here with lots of siblings, I presume, who really form a supportive network, and the idea is to get them involved in the same sort of thing. So that's another very big issue. Now, when a patient comes to see you, and I always make a point of talking to the patient, because I think oftentimes, especially with children, you tend to talk to the family and you don't tend to talk to the child as much. And there are lots of little gems that the child can tell you, something about the seizure, but also very often about what their feeling is. You get a sense of what their fears are. And that's missed if you just talk to the parents and avoid it, and don't talk directly to the children. Do I need to be on an AED? These are the expressed fears. Can I drive? Parental concerns, especially with a son, dependent, and dependent daughter. Unexpressed fears in my adult patients would be financial independence. Can I work? And will I ever be normal? Will I love and marry? Will I give my child epilepsy? These are huge issues. And I can't tell you the number of times I've seen such terrible guilt that comes through with, I must have done something wrong in the pregnancy for this to have happened. And that's a huge burden that to bear. Will I ever be independent? That's another very big issue. So what we're talking about really is transitions from the pediatric age, to which Dr. Abram talked about, to where Dr. Tatum talks about the adult age. And transitions are easy to talk about, but so difficult to do. And let me tell you that when a person is pregnant, when a family is pregnant, they don't really think of that child as a little blob of fat and lovely, cuddly smiles and things of that. They're sort of imagining this child off to college, and off married, and up as a teenager. And suddenly when you have epilepsy strike in this young age, suddenly there are lots of fears that come up. Will my child ever be normal? I mean, I was thinking about this. We don't tend to think of a child just as a 1-month-old. We tend to see the whole spectrum in one shot. And so it's very damaging to the psyche. And I can tell you that this is my daughter, who does not have epilepsy, but transitions, I can tell you, are pretty scary regardless. Here she is with 5, with M&Ms on ice cream. And there she is, all on her own in China. This is the Great Wall of China. This was a school trip, and she spent a month there. She speaks Mandarin, of all things. I can barely speak any other language other than English, and here she is with Mandarin. So that's a transition. And of course, the reason why I have no hair is because of this other transition that takes place. And this is winter formal. So really, when you talk about this in a normal situation, there are already anxieties related to growth and development, to independence. Are they going to be okay? Are they going to be good people? Are they going to be happy? And when you add in this horrible cloud of epilepsy, it really adds, the magnitude of the problem just increases. I had a patient once who was 27 years old who told me that if he had to add up all the seizures that I had in a year, it would probably be less than 10 minutes. And yet every single day it affects my life. And that's the wickedness with this condition almost. It just is there. You never know when it's going to strike. It's not something predictable. It's not like your diabetes where you ate a little bit extra, you didn't take your insulin, and your sugar is low, and you know why it is. This is for no reason it happens. So it's very, very bothersome. Dr. Abram talked about the fact that a lot of children have benign epilepsies, quote-unquote benign epilepsies of childhood. They outgrow it. And anytime you have a patient that has an epilepsy, anytime you have a young adult that comes to the emergency room with a first-time seizure, and they're otherwise completely normal, chances are 25% of them will have juvenile myoclonic epilepsy. This is a condition that oftentimes is not recognized for what it is. And once you recognize it, you know the treatment that is most effective, and this always stays controlled with medication. So it's an important thing to recognize. There was a study, and this is out of Sweden, where apparently, just like Olmsted County and Mayo, Rochester, where they follow people for 30 years, in the U.S., when 20% of us are moving every year, or every 5 years, it makes it difficult to do this. But this is a follow-up of 245 children with epilepsy, and follow them for 35 years. And obviously, these were not the benign epilepsies. And they found that education levels were lower, employment rates were lower, marital status was lower, physical fitness was lower, and psychiatric comorbidity was higher. It's not surprising. It's not surprising. Where do seizures come from? They come from the brain. Where do psychiatric problems come from? They come from the brain. It's not surprising that there may be an interaction between the two. And I think the issue here is not to feel low about it, but to really recognize it. When a patient is telling you that their mood is changed, to really take that into consideration when you're talking about a treatment plan and talking about treatment issues for this.